physician-patient relationship. If a patient denies life-saving treatment, under what ethical principles are physicians obligated to comply with the patient's demands? Or could physicians simply override the patient's wishes and act paternalistically, in other words, according to their best judgment? These sorts of ethical questions on where the balance of power lies have been asked for thousands of years, dating back all the way to the ancient Egyptian times. Of course, back in 4000 to 1000 BC, the current conception of physician-patient relationship was more of a priest-supplicant relationship, but that relationship still existed. As medicine advanced, this power shift alternated continuously, challenging the previous guiding ethical principles of patient care. However, external socioeconomic and political factors that had nothing to do with the advancement of the field also influenced how this relationship evolved. Imagine yourself as a patient in the 18th century. If you were poor, you did not have the privilege of going to see a doctor. It was only the rich aristocrats who hired these small number of doctors to be taken care of. Doctors competed against each other to be hired by these rich patients and tried hard to please them. Thus, the dominance over the relationship ultimately lied with the rich patients at this point of time in history. But as hospitals started emerging later in the century, and as doctors started discovering that symptoms were not illnesses in and of themselves, but indicators of an underlying pathology, the medical field called for more expert knowledge of doctors, and patients started depending on their specialty, slowly shifting this dominance over the relationship to the physicians. Now, fast forward to 1964, a physician named Bayland promoted mutual participation in medical decision-making. He thought interaction that is based on equal power and autonomy as unique individuals ultimately enabled patients to take care of themselves. For many Western doctors, this form of equality was crucial to democracy and egalitarianism. Their satisfaction now was not to be derived from control and dominance over their patients, but from the extraordinary service they provided to humanity. And this model of mutual participation is the bedrock of fiduciary relationship that is seen in modern Western medicine today. It is a trusting relationship that presumes to treat patients if it offers them medical benefit. But at the same time, patients can stay autonomous. That is, they have the right to govern their own body according to their best judgment. And this right extends to the ability to refuse a medically beneficial treatment. For example, for the reasons of avoiding too much suffering, or for religious and cultural reasons. Doctors today cannot force an autonomous adult to comply with the treatment. They have to gain their informed consent. So what is informed consent? You can think of it as a permission granted by the patient who is aware of what he or she is giving permission to. And what does it entail? First, there needs to be a disclosure of medical information to the patient from the doctor. That could be risks and benefits of treatment, prognosis, alternative treatment options, consequences of having or refusing the treatment, and etc. And secondly, the patient needs to be competent in accepting or foregoing treatment on the basis of this information. Understandably, the term competent can be subjective, and it can be difficult to monitor one's competency when the patient is in a vulnerable position, coming in with tremendous stress under their shoulders. So the medical field is doing their best to account for this subjectivity with various psychological competency tests, and debates regarding this topic within the bioethics field is still ongoing. But if these two conditions of informed consent are met, a patient can give an informed consent to accept the treatment or refuse a treatment. The logic is, if a patient is competent enough to accept a treatment, they are competent enough to refuse one. However, there is a catch. Life is not always that black and white. There are cases when informed consent itself can be tainted. For example, a competent patient who understands the procedure can be coerced or subject to undue influence to make a decision. Perhaps there is a malicious family member influencing the patient's decision or a financial incentive. these possibilities need to be accounted for when evaluating a patient's informed consent. Alright, in the final scenario, what happens when the patient is not competent to give informed consent? Then either a surrogate who can represent the patient's best wishes can make medical decisions for them, or an advanced directive, such as a living will, can be used. As you can see, informed consent in various topics related to physician-patient relationship is not so one-dimensional, and nobody knows how the current conception of what's best for this relationship might change in the future. Perhaps we would need to account for the patient-machine relationship in the not-so-distant future. This topic is something we all should contemplate on, while at the same time appreciating the progress we've been able to achieve. Thanks for listening. Hi guys. So two of the most interesting courses that I took in my undergrad was medical philosophy at the University of Alberta and history of medicine at the University of Cambridge. And physician-patient relationship was one of the topics that we talked about in these courses. And I hope that you found these materials as interesting as I did. I just moved back home to Edmonton, where I'll be studying my medical school. And my plan is to keep on releasing these types of videos that will prepare you for your potential upcoming medical school interviews. It's good to know about these kind of things, so keep in tune. Thanks for watching.